Sorry. Good evening, everyone. Hello. I hope all of you are doing good. So this is the last day.
Welcome to Urban Audio.
Please mute yourself, guys. Okay. So hello, guys. Please mute yourself first of all. Okay. Yeah. RVH, LVH, RVB, LBBB. We'll discuss everything. Um, with the quiz also, and somebody told about certificate. So, no issues actually about the certificate. I was talking about certificate. So I will share a Google form with all of you today on the group. So just fill that form and put the name very carefully in that, because whatever you name, put into that. Like for example, my name is Dr. Vishal Gabale. So if I only put Vishal, the certificate name will be only Vishal. Okay. So likewise, whatever the name you want, in the name section, you just write it down. Okay. Make sure you fill that form. Right. So today I will share that, so you can get certificates within next 2-3 days. All right. So let's start. I'll start sharing the screen now. Okay. Just a second. Are you able to see the screen properly? Okay, just give one minute. I'll just put phone on charging. Charge. All set. All set. So let's go ahead and discuss about the ECG. Today, we're going to discuss about the STEMI equivalent and arrhythmias. Before that, I will just quickly revise what are the things we yesterday discussed. Okay. Just a second. Okay, so yesterday we discussed about the myocardial infarction, and you know what are the things in the myocardial infarction now in detail. So we discussed about anterior volume. We discussed about the inferior volume, V2, V3, V4, V5. All right, inferior volume 2, 3, and AVF. Okay. We discussed about the anterolateral. Before that, we discussed about the RVMI. Then we discussed about the posterior volume. Okay, so RVMI was V1 having ST elevation. Okay, V2 can be isoelectric or ST depression. All right. In posterior volume, V1, V2, V3 all had ST depression, and that to what? Horizontal ST depression. Okay, so that's about the yesterday's part. Let's focus on the quickly. Let's see those ECG. Can anybody tell me the diagnosis of this one? Is the screen okay now? Can anybody tell me diagnosis of this one? Yes, exactly, posterior volume. Because you can see this ST depression is kind of horizontal, right? So this has to be what? Posterior volume, because these are the reciprocal changes. All right. Then can anybody tell me about this ECG? It's also posterior volume. Okay. So it's not very well visible. Can anybody tell me about this one? Can anybody tell me about the diagnosis of this ECG? You can see ST elevation in 2, 3 AVF. So that's inferior. Plus V1, see ST elevation V1 and V2. So what? Let's do V4R now. Let's check V4R, and yeah, we have got V4R, which is also showing ST elevation, isn't it? Therefore, it is inferior volume MI plus right wall MI or right ventricular MI. Is this clear? Okay, so not anterior inferior, guys. This is RVMI. Okay, if it would have been the anterior inferior, then you would have seen in all the V3, V4. Okay, see here in the V4, ECG is normal. Okay, because V4 is placed over here. But if you replace it and place on the right side, that is called as V4R, isn't it? And that's why you're seeing ST elevation, because we have placed it on the right side. And that's why it is only RVMI and not anterior volume. Okay. All right. Now answer this one, guys. Okay, this is written over here. Here. What is this pattern called as? What is this pattern is called as, guys? Anybody? Quickly.
अरे यार ते कोणतं तरी नोट्स शार्क फिन
Very good. Shark fin pattern. Very nice. Very nice. Okay. Yes. Okay. Please mute yourself and write down your answers, please. Okay. Okay. So this pattern is called as shark fin pattern. Okay. And there is one more pattern. Can anybody name that pattern in the anterior volume? So that was typical for the anterior volume. What is this pattern, guys? This is tombstone pattern. Okay, or tombstone pattern. Exactly. Very good. Very good. So this is about the anterior wall MI. So you are very well versed about the MI. Now what we should know about is, we should know about the STEMI equivalence. So why it is called a STEMI equivalence? Because this doesn't present as a STEMI or like ST elevation, but it should be treated as a STEMI, that is ST elevation MI. So what is treatment for STEMI or ST elevation MI? Whenever there is ST elevation, what is treatment? You do thrombolysis, right? We do thrombolysis, right? We will see about the treatment part. Don't worry about that. So we need to do thrombolysis, or we need to plan for PAMI. Why? Because it is emergency case, and the like larger amount of the heart muscle are at the stake in these cases. So that's why we do STEMI. But that's why we do thrombolysis in a STEMI equivalent. So let's quickly revise, very fastly revise, what are STEMI equivalents. First of all, we have is conventional STEMI, that is ST elevation MI. So that's normal. Second is this D Winters T wave. So what happens in D Winters T wave? In V1 to V6, there is this upsloping ST depression, isn't it? Yesterday we saw we have like three types of ST depression: upsloping, downsloping, okay, and horizontal. Okay, so horizontal was something associated with the posterior wall MI, isn't it? It was associated with the posterior wall MI. Okay, downsloping. So which of the following is very least likely to have myocardial ischemia? Upsloping, very nice. All right. So downsloping and horizontal are the only important types for us. So whenever you have this upsloping type of ST depression, okay, and particularly in V1 to V6, this typically presents what? Your D Winters sign. Okay, also called as D Winters T wave. Okay, it ends up being a tall T wave, isn't it? So that is called as D Winters T wave. Look at this T wave, very tall. Okay, so this is definitely a important sign for the coronary artery disease. All right. Then we saw about this horizontal ST depression. All right. It looks like a ST depression, but it needs to be treated as a STEMI. And that's why it's a STEMI equivalent. Got it? So posterior wall MI is a STEMI equivalent. No doubt about that. So till now we saw D Winters T wave and we saw posterior wall MI. Now let's see a syndrome or Wellens sign basically. So this is Wellens sign, a biphasic T wave. Huh? In initial part, it is going up and then it is going down. Here, it is directly going to the down. Okay. So this is uniphasic or deeply inverted T wave, isn't it? It is a deeply inverted over here, whereas here it is biphasic. Easy. So how many we have seen till now is D Winters. All right. We have seen your posterior wall MI and Wellens syndrome. We have two more. Okay, we have two more. Let's see those now. So I will explain this. Don't worry about that. When we see the Wellens syndrome, we will explain that about the Wellens sign. Then we have hyperacute T wave. That's again one of the STEMI equivalent, right? In the early phase. Then we have Sgarbossa criteria. So Sgarbossa criteria is something, it is used for the left bundle branch block ECG. Okay. For the LBBB ECG, it is used. Similarly, here you can see this is again Sgarbossa criteria. Okay, the modified one. Okay. So depending on that, we will discuss Sgarbossa criteria as well. So Sgarbossa criteria typically described as whenever you have concordant ST elevation. So this type of ST elevation is concordant ST elevation. So what does concordant ST elevation means? Whenever your QRS is upgoing, R wave is tall, there is a ST elevation. So it's a concordant ST elevation. Now here you can see there is a negative R wave and there is a negative ST segment as well, or ST depression is there. So it will be concordant, but it is ST depression. Because it's in the same direction. That's why it's a concordant. Now here you see your QRS is in the negative direction and ST is elevated. So this is what? This is your discordant ST elevation. Got it? So concordant ST elevation, concordant ST depression, and discordant ST elevation. So the points given for the concordant ST elevation is 5 points. Concordant ST depression is 3 points, and discordant ST elevation 2 points. So if the total score is more than 4 or 5, then you diagnose the patient as a MI. So that was the old criteria. Now currently for each of this finding, we just give 1 mark. And if you have more than 3 points, that's called as MI. Okay. That's about the Sgarbossa criteria. And it's typically used in left bundle branch block patient or typically used for the left bundle branch. So on YouTube, it might be lagging a bit, but don't worry about that. Okay. So yeah, I'm again going to explain Wellens. That's why I'm not explained at the first place. Okay. Then we know about the shark fin. So I don't want to repeat it again. Can you tell me quickly which one, which type of MI? Shark fin? Posterior wall. No. Not, inferior wall MI. Got it. It's seen in the inferior wall MI. Okay, similarly, acute ischemia in LVH. So here you can see this type of deep Q wave followed by the ST elevation. All right. So this type of morphology is seen in the LVH patient with the acute ischemia. All right. So now let's see the Wellens syndrome in detail. All right. So Wellens syndrome is basically what? Okay. So whenever patient has a chest pain, okay, patient has a chest pain, his ECG will look normal. Okay. And when patient is chest pain free, his ECG will show T wave inversion. Please mute yourself. Hello. Okay. Okay. This ECG will show T wave inversion. And why does it happen? That's because of the pathophysiology in the Wellens syndrome. It is associated with the proximal LED lesion. Okay. Proximal LED lesion. Now, what happens in this patient? Just let me tell you. Whenever patient will be chest pain free, okay, the ECG will appear like this. Look at this biphasic T wave inversion. Okay, there is upper phase, then downward phase. Upper phase and then downward phase. So this is called as biphasic T wave inversion. It is Wellens type A. It is not so common. 25% of the patient has this. Then here it is deeply inverted T wave. You can clearly appreciate that deeply inverted T wave. Deeply inverted T wave. So it is even seen in almost 75% of the patient. So what happens, guys? As there is a deeply inverted T wave, whenever you have chest pain, you develop ST elevation. Got it? But in this patient, as there is already ST depression, not ST depression, but T wave inversion. So when ST elevation occurs, okay, it will look like this. That means it will reverse this T wave inversion. And this ECG looks absolutely normal when you have chest pain. And that's why I've written over here, whenever chest pain is there, ECG appears normal. Okay, ECG doesn't become normal, it appears normal. Okay, let's see the example. So see this one patient who presented with a chest pain. Initially, he has ST elevation in the anterior leads, right? Look at this ST elevation in the anterior leads. All right, there are ST elevation. Now, let's look at other part of this ECG. Now, as patient has chest pain is improving, okay, chest pain is resolved or reduced. Now you can see there is a development of this biphasic T wave inversion. Got it? So this is biphasic T wave inversion when patient doesn't have any chest pain. Now let's see if the patient has chest pain, what happens. Again, patient started having chest pain, diaphoresis. You see this looks thoda normal, not completely normal, but the ST elevation is there. 1 mm, 1.5 mm ST elevation is almost there. And if you can closely look over here, if this chest pain continues, okay, if this chest pain continues, again, you will develop ST elevation. All right. So that's why whenever your ECG is like this, it looks absolutely like little normal over here. Not absolutely normal, but you can appreciate this ST elevation is not much as compared to the other when the patient has chest pain. Similarly, when patient has no chest pain now, symptoms are improving here. You can see ECG is getting back to the normal limit. And again, now this chest pain free, you can see T wave inversion is developed now. So this is nothing but your chest pain free episode with T wave inversion. Okay, but again, now if patient has a chest pain, so what will happen? This T wave inversion. Okay, so I will draw a diagram. T wave, QRS. Okay, this T wave inversion was there. Now, if I have a chest pain, got it? So during chest pain, ECG might appear normal. So that's about the Wellens syndrome, and that you check in V1 to V6, typically in proximal LED stenosis. Okay, so that's about the Wellens syndrome. Any doubts? I hope no. Now, next part is what is Sgarbossa criteria. So Sgarbossa criteria I already explained to you. This is what concordant ST elevation. Got it? So this is concordant ST elevation. This is what your discordant ST elevation. This is what your discordant, sorry, concordant ST depression. Got it? So this is QRS is positive with ST segment elevated. Here QRS is negative with ST segment elevated. Here QRS is again negative with ST segment elevated. So that's about the Sgarbossa criteria, guys. And whenever your Sgarbossa's criteria, according to the modified guidelines, you can see ST concordant elevation more than 1 mm, score 5. So this was original criteria, original 3 criteria. ST depression more than 1 mm, it is concordant, score is 3. Excessively discordant ST elevation more than 5 mm, score is 2. And if the total score, according to the new guidelines also, if it is more than 3, it has high specificity, almost 90% for the myocardial infarction. Let's see this with the example. So here you can see this patient has what? There is a discordant ST elevation. Okay, there is a discordant ST elevation. How? Just look at this. QRS is negative and ST elevation is there. So this is what? Discordant ST elevation. Got it? So this criteria, this itself has more than like 5 marks. All right. And therefore it fulfills the Sgarbossa criteria for myocardial infarction. Okay. So there is 1 mm concordant ST elevation. There is 5. Okay. So this is discordant only. And here they are saying about the concordant. Okay. This is about the concordant ST elevation in AVN. So that's how you diagnose the patients in case of left middle branch group. Okay, so both type of ST elevation is there in this patient. So that's about the Sgarbossa. There's one more example over here. You can see. Now, what type of ST depression is this? Can anybody tell? It is concordant. So if it is discordant ST depression, just write down DST. If it is concordant ST elevation, write down concordant ST elevation. Or concordant ST depression. What do you think, guys? What is this? Don't look at this. Okay. Very good. This is concordant ST depression, definitely. Okay. So as this is concordant ST depression, it fulfills the criteria for the Sgarbossa positive for the myocardial infarction. And that is the simple thing you have to do. Okay. Finally, coming to the conclusion of myocardial infarction with the close DDs like acute pericarditis. So what will happen in acute pericarditis? There will be ST elevation in all leads, right? And there will be no reciprocal changes, isn't it? There are no reciprocal changes here. In case of myocardial infarction, you will have ST convex upward, isn't it? There is a convexity upwards, and there will be reciprocal changes. Got it? And this is about the myocardial infarction. Then benign early repolarization. Obviously, ST elevation will be there at the J point, but this will not fulfill the criteria for myocardial infarction, and there will be no reciprocal changes. Okay. So just remember that. And talking about the ST-T ratio, so ST segment to T segment or T wave ratio. So let's talk about this. So ST elevation to T wave ratio, here it is more than 0.25 and here it is less than 0.25. So that's one of the DD that helps you to diagnose the early repolarization versus acute pericarditis. Got it? So again, as you can see over here, in case of it will be obliquely straight in case of myocardial infarction. All right. Then it can be concave and it can be non-concave. All right. SAD. So this is about the features you can see in myocardial infarction about the ECG. Now let's quickly go through the features of the pulmonary embolism. So what is the most common feature in pulmonary embolism? Sinus tachycardia, S1 Q3 T3, RVH with strain, or. Tell fast quickly. Somebody saying already. Somebody saying S1Q3D3. Anybody else? What about on YouTube? Is anyone watching on YouTube also? All right. So, guys, sinus tachycardia is the most common sign. Okay, that may just be a shock for you, but this is the most common abnormality seen in almost 44% of the pulmonary embolism. Okay, followed by complete or incomplete RBBB in 18%. So, somebody is asking in the chat box how to differentiate between LBBB versus RBBB. So, guys, first of all, LBBB, RBBB. I will just cover you. I don't know why you are guys so worried about this. Okay, it's very easy to understand this. All right. So if you see ECG like this, all right, and like this, so it is V1 and it is V6. Okay. If you see this type of ECG, this is called as RSR dash pattern. If you have this RSR dash pattern, it is definitely RBB. Okay. That is right bundle branch block. Similarly, if you have this W pattern, it is definitely RBB. All right. Similarly, if you have this pattern, okay, closely see this pattern. Okay. Right. So if you have this pattern in the B1 and this pattern in B6, definitely this is your LBBB. And always in RBBB and LBBB, what will happen? Your QRS is prolonged. Got it? So that's about the simple thing, right? QRS is prolonged means how many boxes? More than 120 milliseconds. Now you tell me how many boxes? One small box is 40 milliseconds. So how many boxes? 3 small boxes. Okay, got it. All right. So that's about the LBBB. Now RBBB. So we're talking about the pulmonary embolism. Most common finding is sinus tachycardia. How much? 44%. Second is complete or incomplete right ventral branch block. And third is right ventricular strain pattern. It is seen in almost 34%. Okay. So this is very important. Then right axis deviation. Somebody has mentioned our right axis deviation as the most common finding. Then you have dominant R wave in V1 and then right atrial enlargement. Okay. And followed by your not very common S1Q3D3 pattern. It is seen only in 20% of the patient. Okay. Followed by clockwise rotation seen in the ECG, that is seen by the help of shift of RS transition. Okay. What is RS transition? Basically, the amplitude of the R wave and the S wave. Okay. Which means like from transition point means transfers from V6 to ahead. V1 to V6 basically. Okay. That implies what? That implies the rotation of the heart to the and leads to the right ventricular dilation. So basically, right ventricles and right atrium is some of the part of the atria is most commonly involved in the ECG. Got it? Talking about atrial tachyarrhythmias, then it has atrial flutter, atrial fibrillation, and atrial tachycardia. Okay, which is commonly associated with the pulmonary embolism. Now let's see some of the ECGs of the pulmonary embolism quickly. So here you can see patient has sinus tachycardia for sure, right? The heart rate is almost like 150, you know? 300 divided by almost 2 boxes over here. Got it? So 300 divided by 2 will be 150. Got it? So that is about the here. Also, if you can see, is there S1Q3D3 over here? Okay, S wave is not there big. Okay. Let's see S1. Yeah, S1 is there. Q3 is there. And T3 is also there. Yes. Now let's see his here in this ECG. You can see V1 is showing this RSR dash pattern. But definitely it's a RBBB. Plus, let's see about the S1Q3D3 pattern. All right. So there is a DPS1. Okay, DPS1 is there. Let's see Q3 and let's say T3. All right. So yes, this is S1Q3D3 plus RBBB. This has to be pulmonary embolism. Is there any doubt? No. Similarly, see this ECG now. Is there S1Q3D3 in this ECG? Can anybody tell quickly? So incomplete RBBB means you will have RBBB with narrow complex. Somebody else. Okay. Yeah, this is exactly. See, S1, Q3 is there and P3 is also there. So this is about the pulmonary embolism, guys. And look at the heart rate. It is almost like more than 100 in this patient. Okay. So let's start with the arrhythmia now. Okay, arrhythmia. So before starting the arrhythmia, I want to ask you a few questions. That a 65-year-old man has presented to the emergency department with palpitations and shortness of breath, and ECG showing atrial fibrillation. And his ventricular rate is 150 beats per minute. Now, he is treated with rate control strategy. So, what exactly is the mechanism by which the AVNRT contributes to the management of his atrial fibrillation? Can anybody tell me? Mechanism of the atrial fibrillation. So, don't worry, I'm not going to scare you with this difficult question. All right. So, just here quickly you can go through. What exactly will do AV node? Anybody? Exactly. Yes, that is the answer. AV node delays the conduction, allowing the appropriate ventricular filling time, and that's going to help the patient to pump the blood. Okay, identify this one now. Answer this one. So that a 55-year-old woman is there who is evaluated by dizziness and fatigue and has ECG showing complete heart block. Okay, heart rate is just 40 beats per minute. She is scheduled for a pacemaker insertion. So can anybody tell me what is the characteristic feature of the His-Purkinje system that explain the patient's presentation? So the His-Purkinje system is sensitive to the changes to the autonomic tone? Not likely. His-Purkinje system has intrinsic pacemaker activity faster than the AV node? No. His-Purkinje system conduction is unaffected by autonomic tone? Yeah, that can be one possibility. His-Purkinje system primarily depends on the parasympathetic regulation? Not likely. So the answer would be what? As I've already told you above the AV node, everything can be controlled by the autonomic nervous system, whereas below AV node, it will not be controlled by the autonomic nervous system. And that's why second degree and third degree heart block, you have to manage with what? You have to manage with the pacemaker rather than your parasympathetic nervous system. Your acetylcholine, basically. Okay, or atropine. So let's discuss about the AV blocks, starting with the bradycardia. Okay, so bradycardia is very easy to understand. But before that, let's just quickly understand what are the pacemaker cells in the heart. Okay, so first of all, we have AV node, isn't it? So we have AV node, sinus node, sinus node. Then we have internodal tracts, then we have AV node. Sinus node, I've already drawn that diagram almost 100 times. You can see again. Here is the SA node, here is the AV node, here is your bundle of His. Here are your right bundle branch, okay, left bundle branch. This is right, this is left. All right. Then it divides into the Purkinje fibers, supplying the each ventricles. Got it? And these are the internodal tracts between the SA node and AV node. Okay. So, is there any doubt about that? No. Superior and lateral border of the right atrium is your sinus node, and that has a pacemaker activity for the heart, isn't it? And that has automaticity, that is the fastest rate of discharge. Okay, it is supplied by the sinus node artery, by the right coronary artery. That also you know, right? Similarly, internodal tracts is between sinus node and the AV node, and there are three tracts: anterior, posterior, and middle. Lastly, AV node. AV node is very important. It is located at the lower part of the right atrium, and it is above the insertion of the tricuspid valve septal fluid. Okay, and it is controlled by the acetylcholine. Okay, so SA node, AV node has a control, parasympathetic nervous system control or autonomic nervous system control. All right, and 90% time it is supplied by the right coronary artery. Talking about the His-Purkinje system, so His-Purkinje system itself can produce some of the rhythm. All right, but remember these are not infected or not influenced by the autonomic influences. Okay, so and also very important, blood supply is by the anterior posterior descending coronary arteries. Okay, so that's why in case of second and third degree heart block, so second and third degree heart block is below the AV node, at the level of His-Purkinje system or at the level of the ventricles itself. Got it? So before coming to the discussion, I just quickly want to revise with you guys that what is the normal PR interval. Okay, so here you can see normal PR interval is almost 100 seconds. Okay, from the start of the P wave to the start of the R wave. Okay, so that's about the PR interval. We have already discussed that almost 3 to 5 boxes, isn't it? I will just change the color. Okay, so normal PR interval 3 to 5 boxes. Okay, so whenever this is your heart, this is your SA node, this is your AV node. All right, this is your AV node, and these are your individual fibers. So here, this AV node is something which is gonna give us a PR interval, because that's gonna delay the signals from the SA node itself. Okay, this is AV node that will prolong the PR interval. So if there is the accessory pathway, this PR interval is gonna be short. Why? Because this will bypass AV node. Got it? But if there is no accessory pathway and there is a blockage, or there is a blockade in case of AV node, which we call as a heart block. Okay, and to be specific, if it's a first degree heart block, what will happen? Your PR interval will be prolonged. So that's what you see in case of first degree heart block, guys. Okay, so this is again one MCQ about the normal period of the each basically interval. So PR interval 120 to 200, that is 3 to 5 boxes. QRS 3 boxes. Okay, QT interval we already know it should be half of the RR interval. Okay, more than half of the RR interval. Now it's like to say if it's a QT prolonged. If it's QT normal, then it should be less than half of the RR interval. That I have explained that day only. Okay, so if these are the two waves, okay, and this is your T wave. So if it is, so if you have to say it's a QT prolongation, so I will just quickly draw. This is P wave. Okay, so these are the two R waves, and this two R wave distance is suppose 10 boxes. Okay, and distance between Q to T is almost like 6 boxes over here. So that is your QT prolonged. Here in this ECG, QT is not prolonged, but okay, I hope you got it. So approach to bradycardia now. Let's quickly see about this. Can anybody tell me what is the diagnosis in this ECG? I will give options. Is this sinus pause? Is this sinus arrest? Is this sinus bradycardia? Okay. Can anybody tell me? Or is this thick sinus syndrome? So it is not thick sinus syndrome, it is sinus pause. Very well said. Okay. As you can see, there is one P wave PQRS. Here is again PQRS. I will change the color of the ink. It is getting confused with that. Okay. As you can see, just again. As you can see, this is one PQRS. So okay, this is one PQRS. This is also one PQRS. And here it is completely paused. All right, there is nothing over here, guys. So this is your sinus pause itself. Okay. So classification of the ECG itself, classification of the bradycardia. And what do we have over here is we have sinus bradycardia, we have sinus node dysfunction in which we have sinus exit block, sinus arrest, your sick sinus syndrome, then atrioventricular block. So atrioventricular blocks are this much. Okay, so we have already spoke about this first degree heart block where PR will be prolonged. No, PR is prolonged. Then second degree heart block, which has two types, Mobitz 1, Mobitz 2, the third degree. Okay, then below that, that is junctional block and ventricular escape rhythm. Okay, let's see the ECGs now. Okay, can anybody tell me what is the first one diagnosis? Quickly, guys. What is this diagnosis? Presentation is lagging in your notes. Probably the issue would be of the internet. I hope so, because in my side, internet diagnosis is very good actually. Okay, this is sinus bradycardia. Somebody is saying, can anybody diagnose this one? If so, this is sinus bradycardia, you are saying, then what is this, and what is this? Quickly, guys. 1, 2, and 3. Tell me the diagnosis of each one. Okay, anybody on YouTube? Anybody on YouTube as such? Uh, Now it's normal, right? I hope it is normal right now. Is presentation lagging for all of you guys? Can you please put the message in the chat box? Okay, so what slide exactly you are watching now? What slide you are able to watch now, right now? Okay, a blank screen is showing over. Okay. That's what I'm saying, right? So I'll just, so basically not like many big things are running on the laptop right now. Okay. I'll just turn on the maximum efficiency of the battery. Okay. I will just do that. Best performance. Just say that the best performance only. Okay, anyways, can you answer this one? Okay. I hope, yeah, I hope no. So I will just explain. No issues. It's all right. Okay. I don't expect you to answer without I'm telling you. Okay. So this is a normal sinus rhythm, guys. This is absolutely normal ECG. As you can see, P wave is there, QRS is there, ST is normal, T wave is there. Okay. And you can see repetition of 2R wave is at regular interval. Okay. So this is absolutely normal ECGs. There's no doubt about that. Okay. Even the heart rate and all, everything is okay over there. Talking about the second ECG, here you can see P wave is there, QRS is there, and the heart rate is, look at this heart rate is. Okay, so it is like 300 divided by almost 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, even 12. Okay, so the heart rate is even low than 30 in this patient. Okay, it's a sinus bradycardia. All right. Then identify the third one, guys. Identify the third one. No. Don't go for Mobitz. We are looking for only sinus diseases right now, not AV node. Okay, initially we'll discuss at least sinus node first, then we'll go to the AV nodes. Very good. Somebody has written sinus arrhythmia. Very nice, actually. Okay, quite impressive. So this is sinus arrhythmia. Why? Because you can see some of the time there is a crowding of the waves. Anna, here you can see there's a crowding of the waves, but here the waves are quite far from each other. So that is because during the inspiration, the waves are coming closer to each other. So this is your sinus arrhythmia. Whenever there is an increase in the, whereas there is a reduction in the RR interval and crowding of the waves, typically occurring in the inspiration phase, that is called as your sinus arrhythmia. It's a completely normal phenomenon and you don't have to do anything. Okay. So this is about the down. You guys quickly answer this one. We have already discussed this. Somebody is saying sinus pause. Yes, we already discussed this. Now, what about this one? Okay, so this is sinus arrest or sinus pause. What about this? Exactly, this is sick sinus syndrome. As you can see, these are waves of atrial flutter. Okay, and these are typically seen. These are all waves of atrial flutter basically. And after that, conversion will occurring and it looks completely normal. So there is sick sinus syndrome. That means there is a problem in the sinus nodes. And because of that, your rhythm is changing regularly. Okay. So that is about the sick sinus syndrome, and this is about the sinus pause. So you got it that after 2 pp waves, 2p waves, the distance of the 2p waves is definitely more. It's like the normal 2 pp is more than the less than the increased 2 pp. All right. So whenever there is a absence of the p wave, definitely the distance between the pp wave will increase. All right. So that's what is given over here. Yes, it can occur either in some toxin related or can occur in age related degeneration of the sinus node, as somebody mentioned. Okay, so now we have done with the SA node. Now let's move ahead to the AV node. All right. So what are the diseases of the AV node you know about? Before that, just tell me the answer to this MCQ. So first of all, the features which best define the AV node block is high grade AV node block. Remember this high grade AV node. So we have three types of the AV node block. First degree, second degree, third degree. In first degree, there will be no block. There will be just delay. In second degree, first type, there will be block. Then there will be increased block. Then there will be more increased block. And at one point, there will be absolutely no passing of the signal from the SA node to the AV node. Okay. The AV node to the other bundle of phase. So that will be your Mobitz 1. Second is unpredictable blockages. That will be Mobitz 2. And third is complete heart block, where there will be absolutely no passing of the signal from the atria to the ventricles. All right. So here, if there is an intermittent atrial conduction block, okay, to ventricles with 2 or more consecutive block P waves, but without complete AV blocks. So this is your definition of high grade AV block. Okay. High grade means not complete, guys. Okay. Complete heart block is different and high grade AV block is different. Okay. So second degree is there. Then there is a high grade AV block and then there is a complete heart block. So don't worry. We'll discuss that with this chart. Okay. So here we have that. So first degree is a delayed conduction, as I mentioned. Okay. So first degree is nothing but a delayed conduction. Okay. Then second degree is what? It is intermittent atrial conduction. Okay. Intermittent atrial conduction. Third degree is what? Third degree is what? It is no atrial impulses. Okay. And then is your high grade AV block here. There is an intermittent atrial conduction block to the ventricles with 2 or more block P waves, but not a complete AV block. So you got it? In case of second degree and third, your high grade, there is an intermittent atrial conduction. But here, in case of high grade AV block, there will be 2 or more consecutive block P waves, but without complete AV block. So let's see the ECGs now. Here also you can see. Okay, I'll just quickly show you that. Types of heart degree block. Okay, the first degree is associated with the slow signaling. Here, in case of this, there will be slow signaling. Okay, here it will be affected. Then second degree, there will be sporadic signals. Some intermittent signals will pass and some will not pass. And third degree means absolutely no signal passes between atria and ventricles. Okay, so here it is shown again. So first degree, here is the location of the blockade in the AV. As you can see, some signals are passing, but they are slowed. Okay, these are slowed signals. Here, signals are not at all able to pass. The signals are not passing from the atria to ventricles. That is your second and third degree AV block. We got it what we are talking about. So nodal block is something your first degree heart block. Okay, here you can see QRS duration is narrow and PR is prolonged. Okay, escape rhythm 40 to 60 beats per minute. So that means this much waves are getting passed. Okay, here escape rhythm is less than 40 beats per minute. Why? Because these are the rhythm produced, these are the contractions produced by the Purkinje system itself. As you know, the Purkinje system itself has the power of contraction. All right, so less than 40 beats per minute, right? Then Wenckebach's period often seen in the nodal block, typically Mobitz type 1. Effect of atropine, very important here. It will be increased AV conduction, and therefore there will be leading to your bradycardia. Okay, not bradycardia. That means it will reduce your bradycardia. It will cause tachycardia. Here it will be no effect at this infranodal. No, infranodal means bundle of His and Purkinje fibers. These are not at all relying on the autonomic nervous system that we have already seen. Then effect of catecholamines. Yes, there is increased AV conduction. Effects of exercise, none or enhanced AV conduction can be seen, and same is there, worsened AV conduction can be seen as the patient is already bad and there is no contraction of the heart itself in a good quantity. So if you exercise, there is a worsened outcome and worsened AV conduction. All right. And how is the prognosis? Here it is better prognosis and it is worse prognosis as there is a complete blockade. So this is about the nodal and infranodal. What is node we are talking about? We're talking about the AV node, guys. Okay. I hope there is no issue with that. Okay, so what are the causes of the AV nodal block? So we have many causes, out of which increased vagal tone, progressive cardiac conduction system, with fibrosis and all, calcification, ischemic heart disease, cardiomyopathy, infections, congenital AV block, etc. These are the causes of the AV block. Along with that, what will be the iatrogenic causes? You know about beta blockers, calcium channel blocker, digoxin, adenosine, and antiarrhythmic blocks. So this can cause bradycardia with the help of AV block. Okay, that will cause AV block. So just remember what drugs. So okay, so beta blocker, calcium channel blocker, digoxin, adenosine, etc. Then cardiac surgery, any sort of the cardiac surgery itself, even transcatheter aortic valve implantation, that is your TAVI, or catheter ablation of the arrhythmias, or VSD closure, HCM surgery, any type of cardiac surgery itself can cause your heart block. Okay, so not only beta blocker, calcium channel blocker, digoxin, adenosine, or antiarrhythmic agents, all types of cardiac surgery can also cause bradycardia or AV block. Okay, so now with this chart, we'll quickly go through how we identify the first degree heart block. Okay, so first degree heart block, we will only see what PR interval will be prolonged. And how is the normal PR interval? 3 to 4, 5 small boxes. Let's say how many small boxes are there. So we have 1, 2, 3, 4, 5, 6, 7, 8, almost 8. Okay, so it is completely prolonged, right? Almost 8 boxes. Okay, so almost 0.32 seconds. Okay, so PR interval is prolonged more than 0.2 seconds. So definitely it's a first degree heart block. Okay, but QRS is narrow. Now let's look at this Wenckebach phenomena or Mobitz type 1 heart block. Okay, so this is nothing but your second degree heart block where intermittent conduction will occur. And the first is Wenckebach's wave. Now what happens in this Wenckebach? Some signals pass, but gradually, they increase, gradually they progressively prolongs until at one point P wave is completely blocked. So let's see here, 1, 2, 3, 4. Almost 4 boxes. Here it can be seen 1, 2, 3, 4, 5, 6. 6 boxes. Here it is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so it was like 5 over here, it was 8, 7 over here, it was 10 over here. And after that, you can see P wave is there, but there is no QRS. All right, so that is what it's called as Wenckebach phenomenon. Why it is important? Because in this patient, treatment is conservative. If you know it's Wenckebach phenomena, you don't have to worry. Otherwise, if it's Mobitz type 2 or third degree heart block or high grade AV block, you have to manage anyway. Okay, so that's why understanding the Wenckebach phenomenon is important. Okay, so this is about the Mobitz type 1 where there is a gradual prolongation. Got it? So that is your Mobitz type 1 in second degree. Okay, but now if there is a no prolongation, but there is sudden loss of PQRS. Look at this PQRS. PQRS is there, PQRS is there, but there is no QRS. Again, PQRS is there, PQRS is there, and there is P, but no QRS. Okay, so suddenly there is a no QRS complex, but PR segment is normal, QRS segment is normal, and PR segment is also normal, as you can see. So this is your Mobitz type 2. Okay, now lastly, your third degree heart block. Third degree heart block is the most easiest heart block to identify because here your P waves will be more than the QRS. Okay, that means your atria and ventricles are beating at their own pace. They are not controlled by each other. Okay, you can see P wave is there, P wave is there, QRS is there, P wave is there, P wave is there, QRS is there, P wave is there, P wave is there, P wave is there, then QRS is there. Got it? So P and QRS are not in relation. That's why it is very important to identify this. Okay, so P and QRS are not in relation. So that is about the complete heart block. And how do we manage it? With the help of pacemaker. Okay, so that is about the heart block. Any doubt about this heart blocks? Mobitz type 2 and Mobitz type 1. Can anybody identify that with the ECG examples now? Is it easy? Is it okay? Are you able to understand? I guess yes. Okay, and these are some of the normal changes in the normal heart you can see. First is sinus bradycardia, sinus pause less than 3 seconds, sinusoid block, natural rhythm, first degree AV block with Mobitz type 1, then pauses up to 4 seconds. Okay, so this is some of the hemodynamic changes which can be seen. So in case of bradycardia and all, your cardiac output, in case of mild tachycardia, your cardiac output might increase, but if you have pronounced bradycardia, okay, your cardiac output will reduce, and that's why it's an emergency. Okay, so whenever you have bradycardia, that heart rate is less than 50 beats per minute. The first step, anyways, is to check ABCD, airway, breathing, circulation, and then you're establishing the IV access figure and decontamination or remove the disability factor if you have anything. Okay, so here we have evidence of, so after checking ABCDE, airway, breathing, circulation, etc., we have to check if there are signs of hypoperfusion there or not. So what are the signs of hypoperfusion? Hypoperfusion means patient will have hypotension, syncope, chest pain, heart failures, and cerebral hypoperfusion. Okay, so in such cases, you have to be a little skeptical. And how do we manage? So if we have to manage with the pacing, we have to prepare the patient. Before that, you can give atropine as 1 milligram IV every 3 to 5 minutes to 3 milligram total. Okay, atropine 1 milligram IV up to 3 milligram total. Okay, so that is about the atropine, which is followed by isoproterenol, adrenaline, dopamine. Got it? And finally, you have to reassess it and do the transcutaneous spacing. We will discuss about the transcutaneous spacing. Don't worry about it. Okay, so we have two options. One is transcutaneous spacing, by which we place the pads on the skin, and next is transvenous spacing, by which help of which we place the catheter, and by venous axis we do the pacing. It is mostly done by the cardiologist, but transcutaneous spacing is something you should do. Okay, so airway, brain, circulation, disability, and exposure is ABCDE. Now, can anybody tell me the diagnosis of this ECG quickly? Let's play a quiz, quick quiz. Okay, someone is saying first degree heart block. Anyone else? Okay, correct. This is first degree heart block, guys. PR is prolonged. Okay, PR is prolonged. Almost like 8 to 10 boxes. Okay, so almost more than 0.32 seconds. So yes, very good, very good. Now identify this one, guys. This is a little difficult, but yes, I hope you can identify it easily. And I have also added what is P wave over here. Okay, so this is a P wave. Anyone? The chat section. Third degree. Somebody saying third degree. Somebody saying ROT phenomena. Okay. So ROT, Mika, it's only when you have ventricular premature contraction. Okay. First degree only. Very good. It is first degree only. Somebody have written. Very nice. I'm actually impressed. Because see, this is P, this is QRS. 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 That means after every P wave, QRS is getting carried out. And as you can see, just PRS distance is increased. Okay, so as I already explained, your PR will be prolonged. And normally it is 3 to 5 boxes. If it is more than 5 boxes, that is almost kitna seconds? That is 0.2 seconds. Let's check how many boxes are there in this case. So we have 1 small box, 2 small box, 3, 4, 5, 6, 7. Okay, so 7 force into 28. Okay, 0.28 second. That means more than 0.2, right? So it is your first degree heart block with a PR prolongation. Okay. Got it. Now identify this one, guys. This one is for you. So patient presented with a syncope and we did the ECG and ECG was showing these features. Anyone? Anyone? Quickly. Anyone on YouTube? Okay, somebody is saying Mobitz type 1, somebody is saying type 1, somebody is saying second degree heart block. So it's a Mobitz type 1, guys. Very well answered actually. As you can see, PR is prolonged, PR is prolonging, PR is prolonged, PR is again prolonging. And here, after this P wave, there is no QRS. Got it? So this is your Mobitz type 1. Very nice. Now identify this, guys, dear friends. Here, see. P wave is there and no QRS. P wave is there and no QRS. P wave is there, QRS is there. P wave is there, no QRS. P wave is there, no QRS. P wave is there, QRS is there.
Third degree also.
Two P waves are not getting carried. These are not getting carried. But there are certain P waves which are getting carried. Okay. So what do you say about that, guys? You know this one. Very nice, high grade AV block. Very nice, Achit. Very nice. So I hope that means you are understanding it, right? So as I've already mentioned, that somebody is saying third degree. Very well. That is also, partially correct. But this is not third degree. Okay, why? I will tell you. Because in third degree, there will be absolutely no relationship between PQRS. But here you can see that after 2 P waves, 1 P wave is getting carried. After 2 P waves, 1 P wave is getting carried. After 2 P waves, 1 P wave is getting carried. So what is the classical feature? This is the classical feature of high grade AV block. That means there is an intermittent communication or intermittent transfer of the signals from the atria to ventricles, and after 2 waves, 1 wave is getting passed to the ventricles. All right, now brilliant students, you guys please answer this one. Yes, guys, please. You can see the number of P waves is definitely more than the QRS. All right, and along with that, there is a no relationship between P and QRS. Isn't it? Is there? Look at this P wave, this QRS is there. Look at this P wave, this QRS is there. And P waves are more. Very good. It's a third degree heart block. Very nice. Okay. So this is a third degree heart block. Now answer this one. This is also a little trickier. Can anybody quickly answer? Okay, I will do denotion for you. There is no PQRS. There is a P wave over here. 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 QRS. The P wave is QRS. P wave is there. QRS is there. This P and R are not in relationship. Okay. So this is a P wave. This is a P wave. This is a QRS. Okay. So absolutely there is no relationship between P and QRS. Can anybody tell me now? This is third degree, guys. This is third degree. No doubt this is third degree. As there is no relationship between PQ and RS, and P are definitely more than the QRS complex. Okay, that means atrial contraction is more than the ventricular contraction, and only few waves are there. Okay, but that is because of the ventricles itself. That is not related to the your P wave. Okay, so this is your third degree. Okay, so I hope it is clear. Now identify this one. Now answer this question, guys. A 72-year-old patient presents with a syncope and his BP is 110/70. What is the first step of treatment after stabilization of this patient? I told no. In high grade, your two to three waves will not get passed and one wave will get passed. Okay, and in complete heart block, there will be no relation between P and QRS. Okay, so you got it? What would you do? First of all, tell me what is this ECG? Is this second degree Mobitz type 2 or it is third degree? Correct. It's a high grade only. All right. This is again a high grade. But here the answer is what? The first answer for high grade. Okay, if this high grade, then definitely your atropine might not help. All right. So we have to initiate the transcutaneous spacing in this patient. That is the answer in this patient. Let's see the treatment of each part. Okay. So this is a brief theory which you can just look afterwards also. I will just fastly revise it for you. So what is the Mobitz type 1? So Mobitz type 1, type 2. So it is this block is more serious than the Mobitz type 1 and therefore it has to be worried. All right. Then wide QRS complexes. Here in wide QRS complexes, that means your Purkinje fibers producing the signal. Okay. And it has potential for the worsening of the block. All right. And what is the treatment for the Mobitz type 2? Okay. So this one second. So this one is Mobitz type 2. Okay. Rather than high grade, I would say it's a Mobitz type 2 because you can see this PQRS, this PRS is quite in a relationship. Okay. And after two waves, these are typically seen. Got it? So this is your high grade. Sorry, this is your not high grade, but rather than Mobitz type 2. Okay. So that is Mobitz type 2. You can get confused with the high grade sometimes. High grade also looks the same, but only thing is there is a PQRS prolongation in that. Okay, in case of high grade. Also, there is a more number of P waves than the QRS complexes in case of high grade. All right. So this is essentially your Mobitz type 2. Got it? Okay. So here you can see Mobitz type 2 heart block. This type of block is typically more serious than the Mobitz type 1, and that's why we have to treat with the pacemaker itself. Okay. Now answer this one, guys. What is the maximum? We will come to the heart block again. Don't worry. What is the maximum cumulative dose of the atropine? We have already discussed that part. 3 mg. Correct. Okay, we start with 0.5 mg and 0.5 to 1 mg, and we have to give up to 3 mg. All right. And remember, in case of the dose lower than the 0.5 mg may worsen the bradycardia. Therefore, it should be more than 1 mg only. And how does it acts? So it counteracts the acetylcholine. Okay. So acetylcholine is a parasympathetic nervous system that causes bradycardia. Atropine is a anti-parasympathetic basically. Okay. Definitely it is effective. So as we discussed, it is not ineffective in Mobitz type 2 and complete heart block. Then what is the most effective drug in symptomatic patient who is on Metexel? So Metexel causes bradycardia, right? So there is one drug that typically helps in beta blocker induced bradycardia. So can anybody tell me about the name of that? Okay, so isoprenaline. Why? Because isoprenaline acts on the beta receptors. All right. So here are certain drugs that can be helped to treat the bradycardia patient. So there is some problem with that. Okay, yeah. So number one is atropine. It is acetylcholine receptor antagonist. Here you can see doses 1 milligram, 3 milligram, started with 1 milligram up to 3 milligram IV. And it can be typically given as a first choice of drug. All right. Relative contraindication includes ileus and glaucoma. Talking about the isoprenaline and isoproterenol, these are one and the same only, and they are given as an infusion 4 mg per minute. Okay, 4 microgram per minute, and they may cause ventricular arrhythmias. Coming to the adrenaline, and those patients who need adrenaline, we should start on the because these are alpha beta agonists, so they can increase the BP also with the inotropic activity, and they can control the bradycardia as well. Talking about the dopamine also acts in the same way, and it can reduce the bradycardia and it can increase the myocardial contractility. Coming to the dopamine, again, it has inotropic activity, and definitely it can be used in patients of septic shock with bradycardia. Theophylline, aminophylline, these are off-label drugs. This can be used in patients some of the times to increase the heart rate. All right, but it presents with a tremor. Then we have glucagon. So glucagon is like last resort, and it counteracts the beta blockers. Okay, so after that drugs, we have this transcutaneous pacing. So this is basically a device that is used for the pacing. Here you will see the ECG and all. Okay, here you will see all the ECGs, how is the appearance of that, and what are the indications? Symptomatic bradyarrhythmias, okay, like sinus bradycardia, AV block, etc. Okay, along with that, it causes overdrive pacing for unstable tachyarrhythmias. Okay, and it can be used as a temporary bridge device between the permanent pacemaker. All right. So how is the procedure? So basically, we have to shave all the region and make sure there is like no wet skin and no hairs. And if there is wet skin or hairs, there will be no passage of the current, right? Basically, what we are giving a current. One electrode placed anteriorly, one electrode placed posteriorly, and you are giving current basically. Okay. So advantages, it is quicker initiation. So we're talking about the transcutaneous spacing. It is quicker, it avoids the complication of the invasive procedures, whereas it is less precise, it requires continuous monitoring, and it may cause chest discomfort as well because it is externally placed on the chest. Okay, then we have transcutaneous spacing, which we by the catheter of the right jugular vein, we put the catheter and we pace itself from the right ventricles. Okay. So with the pacer in the right ventricle, we start the pacing. Okay. So complications. What are the complications of the transvenous? As it is invasive procedure, obviously there will be infection, perforation, tamponade. Okay, and it may require higher competence and carries some risk. That's why only cardiologist does, and therefore it is not first line choice in case of emergency situations. Now coming to the tachyarrhythmias, that is the last part of today's discussion. So we'll take like 2 minutes break before that, and we can start with that. Yes. I've not shared these notes. I will share these notes as well. No problem. Okay. I'll share this annotated PDF and these notes also on the group today itself. Don't worry. Okay. So, all right, let's start with the tachyarrhythmia, which is again a very big topic, but I'm very confident that we have gone through all of this already because when we're discussing the QRS complex and QRS duration, we have gone through that, right? So, tachyarrhythmia based on the QRS duration are divided into the two groups. First is bradyarrhythmia, first is supraventricular and the other one is ventricular. Okay, so here supraventricular less than 0.2 seconds, you know that because it passes through the traditional pathway, and that's why it's called a supraventricular. These are rarely dangerous and this can be managed with vehicle manuals. All right, then talking about the QRS, talking about the tachyarrhythmias with QRS more than 0.12 seconds, this can be supraventricular tachycardias with some pre-excitation activity. Okay, so supraventricular with bundle branch block, hyperkalemia or aberration, okay, aberrant pathways or pre-excitation, like in case of WBW. Okay, so these are generally not dangerous, but yes, we have to manage this. Coming to the ventricular tachycardia, always dangerous, and we have to always manage these patients. All right, so this is about the classification of the tachyarrhythmias on the basis of the QRS complex duration. Okay, let's start. So again, here tachyarrhythmias, we have already discussed that. So if it's narrow and regular, we have already discussed what are the irregular tachyarrhythmias. So I'm not worried about that now. So what is narrow? Narrow is narrow QRS and regular is regular RR interval. Okay. So sinus tachycardia, supraventricular tachycardia like AVRT, AVNRT, okay, orthodromic AVRT, then atrial flutter with fixed AVCR, that is atrioventricular conduction, then focal atrial tachycardia and junctional tachycardia. So all of these have regular RR interval, which would be irregular. Irregular is atrial fibrillation. You know that. It is narrow complex because it is a supraventricular. It is atrial fibrillation. Okay, and therefore it is irregular. Then atrial flutter with variable AVCR. So now in the first day itself, we discussed that the atrial flutter has a different types of blocks. Sometimes there is 2:1 block. That means after 2 P waves, QRS will be getting carried away. In case of 3:1, after 3 P waves, QRS will be getting carried. After 4 P waves, your QRS will be getting carried away. Okay, so that's how you have your atrial flutter with variable AV conduction blocks. So atrial fibrillation, atrial flutter with variable conduction, and multifocal atrial tachycardia. Okay, you also know because if it's coming from different focuses, that will definitely called as multifocal atrial tachycardia, isn't it? So that is your matter. Okay, so then wide and irregular. So what in wide and regular. So what will be wide and regular? We have again multifocal ventricular tachycardia, then supraventricular tachycardia with aberrancy, then our antidromic AVRT, hyperkalemia, and sodium channel blocker. Okay. Similarly, wide and irregular, we have atrial flutter with WW, that is atrial fibrillation with pre-excitation, that is WW. Then atrial fibrillation with bundle branch block, then polymorphic ventricular tachycardia, and then hyperkalemia. So you got it, what I mean through this. So this is a very important, these two are very important charts that you must. Okay. Coming to the causes of tachycardia. We saw the cause of bradycardia, now the cause of tachycardia. Same way, we have some physiological causes and some pharmacological causes. So exercise, pain, anxiety, right? Hypovolemia, hypoxemia, acidemia, sepsis, anemia, pulmonary embolism, cardiac tamponade, hypothyroidism, hyperthyroidism, alcohol withdrawal. So all this agitating condition will definitely have tachycardia. And what are the medicines? So adrenaline, salbutamol, your isopronolol, dobutamine. Okay, then amphetamines, cocaine, methylphenidate, then antimuscarinic like antihistaminics, tricyclic antidepressants, or carbamazepine, atropine, others like caffeine, theophylline, marijuana. So in this all case, tachycardia will occur. Okay. And this normal heart rates in children we have already discussed. Okay, so up to 6 years, around 120 is normal. So first ECG is this. Can you tell me the cause? So let's start discussing the sinus, tachyarrhythmias. Basically, the first one is sinus. Can anybody tell me the name of this arrhythmia? Quickly, guys. Anybody? Yes. Quickly. Fast. Very good. This is sinus tachycardia, right? You can see P wave is there. There is a QRS. There is a T wave. Anna? Very quickly, the heart rate is around like 300 divided by 2. That is 150. Okay. So the heart rate is 150. This is sinus tachycardia. No doubt about that. And handy tip is there. Here you can see the T wave and P wave are quite merged with each other. So this is T wave. This is P wave. And this look like what? Camel hump. Anna? That's why it is called as camel hump appearance. Therefore, remember this sinus tachycardia is very common and associated with this camel hump appearance. Okay. So now let's discuss the SVT by the site of origin and the regularity. So you know if it's a regular atrial, it's a sinus tachycardia, atrial tachycardia, atrial flutter are regular, inappropriate sinus tachycardia regular, sinus nodal, re-entered tachycardia are regular atrial. Whereas irregular atrial fibrillation is irregular, atrial flutter with variable block and multifocal atrial tachycardia. Okay, same thing written in like different charts. So just don't worry about that. And remember these basic things that atrial fibrillation, atrial flutter with variable blocks and multifocal atrial tachycardia are the atrial irregular. Whereas talking about the ventricular irregular, we have polymorphic ventricular tachycardia. That is your ventricular tachycardia in general. Then atrial flutter, atrial fibrillation with WBW. Sorry, that is only atrial, but that is broad complex. Then again, regulatory ventricle, AVRT, AVNRT, and automated junctional tachycardia. So these are AVRT. Okay, rather than atrial, I would say it's a atrioventricular. Okay, that node is there, and both of the atrioventricular are involved, but it is again a narrow. Got it? So it involves the AV node basically. Got it? So that's about the classification of SVT. Are you clear with this? Any doubts? Now let's see the ECG, guys. Please identify this ECG. You already know about this one. Okay, look, that PR interval is prolonged and P wave is in ectopic. P wave is ectopic. Can anybody tell me? PR interval is not prolonged, sorry, it is shortened. Can anybody tell me the diagnosis? Very good. It's the accelerated junctional rhythm. All right. Or also called as focal atrial tachycardia if this distance is much more. Got it? So this is your focal atrial tachycardia or accelerated junctional rhythm. Now anybody can tell me about this one? Are there P waves over here? No. Look at this T wave. Look at this T wave. Only T wave is there. No P waves. So this is nothing but your supraventricular tachycardia, which is of mainly two types, AVNRT and AVRT. Okay, AVRT is something in which the accessory pathway is present. So you know if accessory pathway is present, that means your PR will be shortened and your QRS will have slurred upstroke, that is called as delta wave. So it should be AVNRT. Let's see now what is AVNRT. Okay, so this is typically AVNRT, which is SVT, which is synonymous with the AVNRT. Okay, here there is absence of aberrant conduction, and paroxysmal SVT or PSVT describes the SVT with an abrupt onset and offset. Okay, so now let's discuss what is the mechanism of the AVNRT, which I have already explained on the first day itself. Okay, so this is the AV node basically. And here you can see there is a circuit around the AV node. Therefore, it is AVNRT. And here there is a circuit between AV atria and ventricles. Therefore, it is AVRT. And basic, there is a circuit around the AV node. That's why it's the AVNRT. And there is a circuit around the AV atrioventricular with the help of accessory pathway. And there is a circuit as developed. That's why it's a AVRT. So what is the mechanism? As I've already told on that day, that during normal conduction, the signals passes through the fast fiber until the time they reaches the slow fiber. Slow fibers are in the absolute refractory period. Okay, but some of the times what happen, if the signal first come through slow fiber and your fast fiber is in the relative refractory period, okay, or effective refractory period, which is the part of the relative refractory period. So this signal should not pass, but they pass. Now, if the fast pathway is in the ERP, so they pass and they goes over here, and because of this stimuli above the threshold level, there is a development of this axis circuit in the AV node, which causes arrhythmia. Okay, so as you can see, this passes up, and because of this, there is circuit conduction, which leads to this AVNRT. Okay, so pathophysiology of the re-entry in the slow fast AVNRT is, as I already mentioned, whenever you have premature atrial contraction which arrives while the fast pathway is still refractory and is directed down the slow pathway, and then ERP in the fast pathway ends and the PSC impulses travels retrogradely up to the fast pathway as shown over here. Okay, as the signals are passing to the fast pathway, it is in the refractive period, that is effective refractive period or relative refractive period. So that leads to the circuit formation, and this impulse continually cycles around the two pathways. Okay, and what will be the electrographical features, electrocardiography ECG features in this patient? You can see there is a no P waves. Okay, look at these P waves. Are you able to appreciate P waves? No, no, right? But these P waves are embedded over here. In case of V1, we are talking about after QRS. So that is called as your R dash waves. Okay, and they are typically seen in which patients? Slow fast pathway. So what does slow fast pathway means? Slow fast pathway means the signal are first going through the slow pathway, then they are transferring to the fast pathway. Okay, so the slow fast way is this, slow fast way is this one, and then they're going to the fast pathway. So what are the ECG features again? It's a regular tachycardia. It's a narrow QRS complex. P waves, if visible, it exhibit a retrograde conduction with P wave inversion. Okay, here also you can see PQRS, and here I will just zoom it a bit. Okay, so in normal ECG, the upper one is a normal ECG. See, there is a normal over here, but here you can see there is a notch over here. Isn't it? There is a notch over here. This is nothing but your P wave. So P wave is occurring after QRS complex, and this is characteristic feature of the slow fast pathway. Got it? Here also you can see. Okay, after this QRS, you can see this type of inverted P wave. Inverted P waves. So that's about your AVNRT, guys. Coming to the AVRT, as I told, AVRT has nothing but an accessory pathway. All right, there is an accessory pathway, and it is very easy to understand. So I will just tell you this concept. If the signals are first passing through the normal pathway and then through the accessory pathway, it is called as orthodromic AVRT. Okay, because signals are passing first through the normal conduction, AV node basically. Okay, and then they are going into the accessory pathway. So that's called as orthodromic AVRT circuit. Whereas if they are passing first through the accessory pathway, that is called as antidromic AVRT. Got it? Antidromic AVRT. So antidromic AVRT necessarily has the broad QRS complex, right? Why? Because definitely the signals are not passing through the AV node. Got it? Therefore, they have broad QRS complex. Whereas here, the QRS can be narrow. Got it? Any doubt? Any doubt till now? In AVRT, MNRT? Okay, here you can see. Live stream is working or not? By the sinus or artery. Okay, just 1 second. I will stop sharing and I will restart the sharing. Just give me 2 minutes. I think laptop is saying this is this is enough. No issues. All right, we are back. We are back. 1 second. I will start sharing. Okay. So that's about the AVRT. Okay. So as you can see in AVRT, there is an accessory pathway. And if the signals are first traveling through the accessory pathway, that will be called as antidromic AVRT. And if it's going first through the accessory pathway, if it's not going first through the accessory pathway, going through the traditional pathway, that will be called as the orthodromic AVRT. Got it? That's about antidromic and orthodromic AVRT. Now, when seeing the ECG, there might be just confusion. Is it AVRT or AVNRT? Then how to just identify that? Okay. So it's very easy to say. So see, as you can see here, there is an appearance of the P wave after QRS, okay, which will not be there in case of AVRT. Okay, AVRT, it will be not there. Along with that, AVRT, there will be prolonged RP interval. Okay, suppose this is your R wave, okay, and this is your P wave. Okay, so this is your R wave basically, this is your P wave. So this is R, this is P. This is quite prolonged. Talking about here, as you can see, this is your P wave, this is your R wave. Okay, it is quite closer. So R wave, RP is prolonged in AVRT. So this is a classic difference and it's a basic difference between the AVRT versus AVNRT. Okay, but important part is knowing this difference is not required. Why? Because treatment of both of them is same. Okay. Okay, ये साइड में क्या कंफ्यूजन हो गया? बहुत इजी है, देखो, अगर इम्पल्स फर्स्ट एक्सेसरी पाथवे से जा रहा है उसको एंटीड्रोमिक एवीआरटी बोलेंगे. ओके, बट इम्पल्स अगर फर्स्ट ट्रेडिशनल पाथवे से जा रहा है तो उसको ऑर्थोड्रोमिक एवीआरटी बोलेंगे. उसमें क्या कंफ्यूजन? सिंपल है, राइट? अर्शल गॉट इट? ओके, याद रखो ए फॉर एक्सेसरी पाथवे, है ना? ऐसा रखो याद, ए फॉर एक्सेसरी पाथवे, एंटीड्रोमिक एक्सेसरी पाथवे. तो फर्स्ट इट विल ट्रैवलिंग बाय द एक्सेसरी पाथवे, ऐसे याद रखना. गॉट इट? सिंपल. So here you got it that in case of your V1, basically in case of your AVRT, your PQRS, your P wave will be not exactly embedded in the QRS complex like AVNRT. Also, PR and RP interval is more prolonged. That is more than 70 milliseconds. Okay, in case of AVNRT. Okay, so that's a theoretical point, but knowing it's all right. If you don't know, that's okay, because it's the SS part. Basically, cardiologists should know that, like electrophysiologists, not even cardiologists. So that's okay. Now identify this one, guys. What is this diagnosis? You know this. Even with the closed eyes, you can answer this one. Can anybody? Yeah, it's a WBW. I've already written AVRT also here. Okay. Now identify this one, guys. First of all, it's a bundle branch block, right? So LBBB, not VTAC actually. Here you can see there is a pre-excitation here. Okay, so there is a pre-excitation over here. Okay, these are all pre-excitation. So this is your LBBB with pre-excitation. Okay, which can be confused with the ventricular tachycardia. Okay, so how do we treat the orthodromic AVRT? So we treat orthodromic AVRT depending on the hemodynamic stability of the patient. So if patient is hemodynamic unstable or like unstable, in such patients, we have to treat with the DC cardioversion. Okay. So we do DC cardioversion if hemodynamically unstable. Okay. Right. And then if it is anterograde portion of the conduction typically affected, then management options should be little slower. You can target the conduction. Okay. So if the anterograde portion of the conduction is typically a weak link, okay, anterograde pathway or your AB pathway, then definitely management option in the stable patient is little conservative. You can go and wait and watch. If you can try for the vasovagal maneuvers or vagal maneuvers, and if that doesn't help, then you have to try for the adenosine and verapamil. That's what is given in this text. Okay, that stepwise approach should be done. So here is the stepwise approach. So whenever you have a SVT, you just look for the symptom. If the patient is unstable, you quickly you look if patient comes to the sinus rhythm. Then if no sinus rhythm, then you have to give the cardioversion to this patient with the help of the your defibrillator. Okay. Similarly, if patient comes to the sinus rhythm, then you have to look for the underlying cause. And if the underlying cause is ischemia, you have to treat that part. Okay. And if patient has appropriate sinus tachycardia, then you have to manage with the IV fluids, etc. What is underlying causes? And if patient is having inappropriate sinus tachycardia, then you have to treat with the IV beta blockers. Lastly, if patient has SVT, you have to check for adenosine. You have to give the adenosine 6 mg. For sure, you have to give this adenosine. Okay, you have to give adenosine, and once giving adenosine, you have to check what is the rhythm of the patient right now. So if AV blockers occurs after adenosine, but tachyarrhythmia is still persistent, then in this patient, you should not administer additional adenosine. Why? Because this patient has an accessory pathway. I will explain. Don't worry about that. I will explain it. Don't worry. Just remember, whenever adenosine is given and patient develops tachycardia, but your AV block is there, stop it. Do not repeat. Why? Because this AV block can worsen the arrhythmia. Let me tell you how. Okay, suppose this is the different color. Okay, so suppose this is the diagram of your heart. Okay, this is your accessory pathway. Okay, this is your AV node. So if you are giving medicines and if you're giving signals from the RA, that is your ST node to the AV node, and if you're giving AV nodal blocking agents like your adenosine, you can stop the AVRT or AVNRT also for that matter. But if you're giving this, so suppose normally the rhythm was passing through the AV node, but now it will pass through what? This accessory pathway directly, uninhibited. Okay, and definitely because of this, all the atrial impulses, which are in the rate of like 300 to 400, will pass to the ventricles, causing what? Ventricular tachycardia, malignant ventricular tachycardia for that matter, and patient will die on table. Okay, that's why, or in ER itself. That's why never give adenosine in patient where tachycardia is persistent even after giving adenosine. Got it? That means it's because of the accessory pathway. And how do we treat this patient? We treat it either with the flecainide, we treat it most importantly by the catheter ablation. I hope it is clear. Similarly, here also you can see if SVT is persistent without AV block. So in this patient, definitely you can give adenosine one more time, right? Because maximum dose of adenosine is almost 12 to 18. So if SVT is there in the ECG, okay, not AV block or not tachyarrhythmia, only SVT is present. There, in this case, you can give adenosine up to 12 mg, then 18 mg if needed. Okay, and if SVT still persists, then you can follow by calcium channel blocker or beta blocker, right? And if SVT terminates, then it's good for us. We just have to monitor. Got it? So this is the treatment algorithm for the PSVT patient or ESVT patients. I hope there is no doubt about that. Just remember, we start with the vagal maneuvers. Then, if patient is hemodynamically unstable, we start with the cardioversion. Okay, and if patient is not getting better, or patient develops the AV block, and patient has some sort of accessory pathway, then you can't give. Okay, then you can't give adenosine. No adenosine. I hope it is clear to all of you guys. All right. Same algorithm for the tachyarrhythmias now. So first of all, we check for the all the parameters. We check for the vitals of the patient. If patient is hemodynamically unstable, we do synchronized cardioversion. If hemodynamically not stable, hemodynamically stable, then we check for the ECG. If it is wide QRS, we consider adenosine only if patient has monomorphic VT or something. Okay. And if it is no, that means narrow QRS, then definitely you have to try vagal maneuvers. You have to give adenosine, you have to give beta blocker. If doesn't help, okay. And finally, if patient has a refractory SVD, we have to treat the underlying cause. There is no other thing you can do for it. Okay. Addition of antiarrhythmic drugs, expert consultation, and all these are different things. So you got the algorithm depending on what type of arrhythmia is there and what is the hemodynamic status of the patient. Okay, and what are the drugs we can use? Synchronized cardioversion, adenosine, procainamide, AVNRT, and sotalol. Now identify this ECG, guys. So we are done with the SPT now. Now we are left with VT. But before that, identify this ECG, guys. This is a part of SVT only. Just for a clue. Okay, look at the regularity. Okay, this is irregular. Anything else you find here which worries you? You're thinking it's a multifocal tachycardia. Okay. Let me see. Okay. I'm not able to appreciate the any P wave over here. Okay. These are not discernible P waves. Okay. I'm not clear cut able to establish it as a P wave. Very good. This is atrial fibrillation. Why? Because see, this RR interval is irregular, and that's itself is a big clue. Okay. In multifocal tachycardia, your RR interval is also irregular, but see the P waves can be clearly differentiated in that. Okay, so let's quickly discuss about the atrial fibrillation. So what are the ECG features of the atrial fibrillation? The first one is irregular, that you know. There is no P waves that you know. All right, absence of electrical baseline, isoelectric baseline. You can see it is completely not isoelectric, right? Then it has variable ventricular rate. Then QRS complexes are less than 120 milliseconds. Why? Because it is a supraventricular tachycardia. Then it is also the bundle branch block accessory pathway or rate related aberrant conductions. And there are fibrillatory waves associated with it. Okay, with amplitude of less than 0.5 mm or coarse, that is amplitude more than 0.5 mm. Okay, and fibrillatory waves may mimic P waves leading to misdiagnosis. Okay, so as I've already explained, the focal activation and multiple wavelengths are two theories that tell us what is the mechanism for the atrial fibrillation. So here you can see normal heartbeat is like this, and in case of atrial fibrillation, there is this type of irregular. Let's see the ECG. Can anybody tell me the diagnosis of this ECG quickly? Directly not VT, guys. AFib is left later. This is not VT, guys. This is atrial fibrillation itself. Okay, but with the pre-excitation. Okay, so this is atrial fibrillation with pre-excitation. All right. So I will tell you what is VT, but before that, you just understand this. All right. This is narrow QRS, no? Why are you talking about broad QRS? Look at the lead 2 itself. Okay, let me show you. Here, look at this QRS. Look at this narrow QRS, okay? These are very narrow QRS. Why are you talking it as a VT then? Okay, here also look at this QRS, this QRS, these are the QRS, these are the QRS. These are narrow QRS itself. Okay, so why are you looking like that, talking like that? Right, so definitely it's a normal rhythm, and to call it as LBBB, RBBB, we need to see what? V1, V2, V3, and V6. All right, so that can confuse you a bit. So you got it? It's the atrial fibrillation with pre-excitation. As you can see, this QRS is slurred. This QRS is slurred. RBB is slurred. So this is AFib with pre-excitation, or is AFib with Wolff-Parkinson-White syndrome. It is seen almost in 20% of the patient, and it can lead patient to degenerate into VT or VFib. All right. So what are the ECG features in the WBW? Same. Rate is more than 200. It's a regular rhythm. Wide QRS complexes can be seen. QRS complexes change in shape and morphology, as you can see over here. Okay, here it is broad, here it is broad, here it is narrow, here it is narrow, here it is broad, here it is broad, here it is broad. Okay, here it is narrow in general, and it is irregular, and axis remains stable, unlike polymorphic VT and VFib, because here it is northwest axis. That's how you confirm. Okay, so it's really difficult to differentiate between the VT and this, but on the basis of the different morphology of the QRS complex and on the basis of axis, you can tell. Okay, so that's how the diagnosis becomes atrial fibrillation with WPW. The slide is repeated. Now, can you tell me the diagnosis in the ECG 1 or ECG A versus ECG B? Who can tell me quickly? A is atrial flutter, and what about B? What about B, guys? See, this is sawtooth appearance. Yesterday only I shown you my very good diagram about the sawtooth. This is saw. Yeah, exactly. This is AFib. Very nice. Somebody have written. This is AFib. These are all flutter waves. Okay. So that is about the atrial fibrillation and atrial flutter. Okay. So how to differentiate between flutter versus fibrillation? So it has identical 1F waves, whereas it has varying F waves or fibrillatory waves. Okay. Here, atrial wave timing is identical, but here it is variable. It is irregular, right? Along with that, this FF interval is more than 180 milliseconds. Here, FF interval can be shorter than 180 seconds. That is the distance between two fibrillatory waves I'm talking. Similarly, here, ventricular response, that is, sometimes it can be 2:1, sometimes it can be 4:1, whereas it here in atrial fibrillation is completely irregular. So that is difference between the flutter and fibrillation. Now, how do we manage atrial fibrillation? So management of atrial fibrillation is on the basis of 3 steps. Okay, that is A, anticoagulation. Okay, then rhythm control, and third is, okay, so I will just write it like that: rhythm control, rate control, and anticoagulation. The first and most important step is to control the rhythm. But if the patient has chronic atrial fibrillation, okay, so if patient has chronic atrial fibrillation, there is a high chance of the clots, or there is high chance of the stroke because of the clots. So what happens in atrial fibrillation? Your atrias are fluttering, right? And because of this fluttering atrias, there is a high chance of the stasis of the blood in the atria. And because of the stasis means the blood is getting collected at one point. Got it? So ये जो blood connect हो रहा है एक जगह पे, so that blood makes blood clots, and because of this blood clots, there is a high chance this blood clots might pass to the brain, leading to stroke, and that's why we do anticoagulation. Got it? Atrial fibrillation के पेशेंट में anticoagulation क्यों करना है? सब arrhythmia में actually in every other arrhythmias there is a less possibility of the stroke because there will be no stasis. Some blood will get pumped, but in case of atrial fibrillation, the heart pumping is not possible because heart is fibrillating constantly. You know, heart is like this. So normally heart should contract like this. But if heart is just doing like this, just flickering, there is no passage of the blood, and because of this, there is passage of the blood, develops the clot, causes the stroke, and that's why we give anticoagulation in the atrial fibrillation. Got it? And that too only give if patient presents late. So if patient has a atrial fibrillation since last 48 hours, okay, and if the onset is more than 48 hours, if it is more than 48 hours, definitely there is a high chance for the clots. Where the onset, if it is less than 48 hours, there might not be possibility of the clot formation. So you can directly do cardioversion in this patient. समझ रहा है? मैं फिर से बताता हूँ, okay? While telling that. So first of all, we have to just check about the history of the mechanical heart valves or moderate to severe mitral stenosis in this patient. Then we have to check for the Chadwick score that gives us the incidence of the stroke in case of atrial fibrillation. Okay, so if this Chadwick score is more than 1 in the male or in more than 2 in the female, we give anticoagulants to this patient, depending on the score. Okay. All right. Coming to the rate control therapy. So initially, we should try to control the rhythm in the acute cases because rhythm control is the treatment of the choice because it improves the outcome significantly. But in certain patients in chronic atrial fibrillation, if you try to control the rhythm, there can again be high possibility of the clot dislodgement, causing the stroke and other complications. That's why you just go for the rate control in the chronic AFib patient. You just give beta blocker. You don't give amiodarone. Okay, as such, amiodarone can also cause rate control for some extent, but it is mainly used for the rhythm control. Talking about the rate control, what we need is just a beta blocker or calcium channel blocker. So what are the beta blocker that can be used? Beta blockers that can be used are metoprolol. What are the calcium channel that can be used? So calcium channel blocker that can be used are diltiazem or dilsane. Got it? So this is how the treatment is done, right? So the first is background therapy. You have to check. Then first choice therapy, you have to check. Okay, therapy after the failure and therapy when the risk of restoring sinus rhythm. So this is basically in which case patients you give the rate control therapy. Okay. All right. So here you have to be a little lenient while controlling the heart rate, should be less than 110. And symptoms and deterioration of the LV function or CRT is quite possible. And that's why you give rate control. Exactly, non-DHP. Okay. So here targets are according to this. All right. So this is about the rate control. And here you can see which drug should be used. So beta blockers, this is the same verapamil are recommended first line drugs. Okay, that is class 1A recommendation, sorry, 1B recommendation. Okay, that means it has been studied extensively and has been proven in different studies. Similarly, beta blockers and digoxin are used in patients to control heart rate in atrial fibrillation patient with LVEF less than 40%. Okay, that is about 1B. Talking about the combination therapy comprising rate control drugs should be considered if single drug is used. Okay, so that's about the rate control in the atrial fibrillation. Coming to the rhythm control, or there is one more chart on the rate control here. You can see what sort of drugs you can use. Okay, so if patient has hypertension or HFpEF, go for beta blocker and non-dihydroxypyridine calcium channel. Okay, NDHCC. Then again HFrEF, you target with the beta blocker. If beta blocker is not helping, then you go for the digoxin. Similarly, in case of severe COPD and asthma, we cannot give beta blockers, right? Because beta blocker is contracting the asthma. So that's why we give calcium channel blockers. All right. Akshita, please remove that strike. All right. So then even though the rate is not getting controlled, then we have to continue beta blocker, calcium channel blocker, beta blocker, calcium channel blocker, and we have to consider digoxin. Okay. And finally, if it is still not getting better, then we have to look for other things like pacemaker implantation or cardiac resynchronization therapy. Okay, so this CRT is nothing but a resynchronization device that tries to maintain the heart. Typically in the heart failure patient, it is indicated. Okay, to control the rhythm of the heart. Because if the patient has already heart failure and if the heart rate increases, there is a high chance of the heart failure, right? That's why we have to consider the CRT therapy. Coming to this case scenario. So this patient has a COVID. This patient has ECG showing AFib. So what will you do? Okay, just look at his findings. There is a sudden onset palpitation. So what you will do? Rate control or rhythm control in this patient? Which one you will choose? Anybody? Will you choose rhythm control or will you choose rate? Exactly. We will choose rhythm control. Why? Because it's a acute. Hai? Now, what are the agents that can be used for the rhythm control? So, wow, like in which condition you should favor the rhythm control? It should be favored in paroxysmal AFib, that is new onset, newly detected AFib, more symptomatic AFib, age less than 65, because there is a chance of stroke if you control the rhythm, right? Then, if patient has no hypertension, heart failure clearly exacerbated by AFib, then no previous antiarrhythmic drug failure, then patient's preferences are low stroke risk with a cardioversion. So in such cases, you should go for the rhythm control. And everything above, apart from that, that is persistent AFib, old AFib, hypertension history is there. You know, patient is taking antiarrhythmic, but that drug has failed now. So in such cases, you should consider rhythm control. Therefore, also along with that, there is whenever there is a high risk for the stroke, you should prefer the rate control. Now, so this is the flow chart for the rate control in the atrial fibrillation. Okay, so same thing we have discussed that in the factors we should favor the rhythm control. That only are mentioned over here, and that's how you do that. Okay, so rhythm control can be done by the amiodarone or can be done by the procedure, that is pulmonary vein isolation. So finally, we have this ECG. And now you tell me what is the diagnosis of this ECG, guys. So done with the atrial fibrillation. Now coming to the second last part of the today's discussion, that is ventricular tachycardia. Got it? So correct, very nice. This is VT. As you can see, broad QRS complexes. Now let's see the features of the ventricular tachycardia. So what are the features? So very important. Always remember this all features, guys. I will write over here. First of all is very broad QRS complex, isn't it? Second is patient will have your northwest axis will be there, right? The third thing is there will be positive concordance. What is this positive concordance? That means all the waves will be positive. All the R waves will be positive. Second is negative concordance. What does that mean? All the waves will be negative. So either all the waves will be positive or all the waves will be in a negative direction. That is called as positive concordance, negative concordance. Along with that, we have certain features. Okay, like fusion bit, capture bit. Right? These are some of the features. Okay, all these features can be present at one point in ventricular tachycardia. Okay, so don't forget this. This is very important, guys. This can be asked to you in any exams as well. So what are the features? Along with that, we have two signs. The one is Josephson sign. Okay, then we have a Brugada sign. So what is Josephson sign? Josephson sign is the notch in case of S wave. Okay, notch in S wave in case of ventricular tachycardia. What is Brugada sign? Brugada sign is nothing but increased RP interval that is more than 100 milliseconds. That is your Brugada sign that we will study. Okay, then I think, yeah, these are some of the important features for the ventricular tachycardia. So second last part, guys, please don't go anywhere. Just listen to me carefully. So very broad QRS complexes, typical RBBB or NBBB morphology can be there. Northwest axis is there. AV dissociation is also there. That means PQRS complexes are at different rates. Along with that, there is a capture bit, fusion bit. So what is capture bit? Capture bit is something in which for example, there is a QRS getting captured with the atrial impulses. Okay, so that means P wave is there, and suddenly with the P wave, QRS will appear. Otherwise, there is a AV dissociation in case of ventricular tachycardia. But sometimes P waves can be carried to the QRS complexes that we call as capture bit. And when sinus bit and ventricular bit both are captured together, that is called as fusion bit. As the name suggests, fusion, right? Because these both are fused together. Right? Along with that, there is a positive and negative concordance, depending on if all the waves are positive and all the waves are negative. So it doesn't matter. Then what is the Josephson? So Josephson is nothing but a notching near the nadir of the S wave. So S wave is a deep wave, right? So if there is a nadir means at the point when it is getting up, or like what you can say is ascending part of that wave, S wave. So if there is a notch over there, that is called a Josephson sign. What is Brugada sign? So Brugada sign is nothing but the distance from the onset of the QRS complex to the nadir of the S wave. Okay, again. So nadir means nothing, your ascending part of the S wave. So if the distance is more than 100 milliseconds, then again that is your Brugada sign. And last is RSR dash. That is nothing but your RBBB. So let's see those feature quickly. So here you can see all the waves are in positive direction, therefore it is called as positive concordance. Here you can see all the waves are in negative direction, therefore it is a negative concordance. So this is nothing but ventricular tachycardia, guys. I'm just telling you the features that you should know while identifying the ventricular tachycardia. Now, this is also a positive concordance, right? But also here you can see during the S wave, there is a notch. So what is this notch over here? So this notch nothing, but it is called as Josephson sign. So this is your Josephson sign, okay? Josephson sign. And whereas this RS interval, look at this RS interval, it is more than 100 milliseconds. 100 milliseconds means how many boxes? More than 4 boxes, right? So each box is 40 milliseconds. So almost 3 to 4 boxes more than that. Got it? So that is almost 2.5 boxes. So one box is 40 milliseconds, no? So almost 2.5 boxes. If it is more, let's say how many boxes? 1, 2, 3, 4. Got it? So if it is more than like it is almost 4 into 4, 160 milliseconds. Okay, so that is your Brugada sign. Now coming to your capture bit and fusion bit. Here you can see this is your QRS complex, and here you can see this P wave is getting carried after the, this is the P wave and this is the QRS complex. So this is your capture and this is your fusion. Capture bit, fusion bit. So this is about the ventricular tachycardia. Now the treatment for the ventricular tachycardia is again easy. You know, if patient is hemodynamically unstable, then you do cardioversion. Okay. And if patient is hemodynamically stable, then you do what? Amiodarone. That is chemical cardioversion or medical cardioversion. Okay. This is electrical cardioversion, depending on the hemodynamic stability of the patient. So amiodarone is preferred. You can prefer other antiarrhythmic agents like flecainide, okay, or abutylide. Okay, abutylide, flecainide are also preferred. Got it? So abutylide is one of the, flecainide is one of the drugs that is available orally and that can be kept in pocket, also called as pocket pill approach. Okay, that is your flecainide. So this is about the ventricular tachycardia, guys. Finally, coming to the polymorphic ventricular tachycardia. Here, typically, you know, because of the dyselectrolytemia and because of the QT prolongation and the dyselectrolytemia, there is a possibility that multiple focuses in the ventricle produces a rhythm that is called as polymorphic ventricular tachycardia. Here you can see this type of appearance is there that typically is called as Torsades lepointis. Okay, it's called as Torsades lepointis. What is this Torsades lepointis? That means it is a twisting around the line. So as you can see, there is a twisting. These are all the waves, and these are twisting around one line. Got it? So that is your Torsades lepointis, and that typically occurs in patients of electrolytemia. Most commonly, hypomagnesemia, hypocalcemia, hypokalemia. Okay, then your QT prolongation paid drugs like quinine, quinidine, etc., azithromycin, clindamycin. All right. So all these drugs can cause QT prolongation leading to the Torsades lepointis. And the treatment is again in this patient, you have to do hemodynamic. If patient is hemodynamic unstable, you have to manage the patient with a shock. Lastly, ventricular fibrillation. So obviously, ventricular fibrillation is always pulseless rhythm, and you have to manage that with the shock. Okay. So this is about the ventricular fibrillation. It is nothing but a chaotic activity of the ventricle. Okay. It is described as a chaotic ventricular activity. Definitely, it doesn't produce any impulse, and definitely patient is gonna die because of it has high mortality. Okay. So this is about the ventricular fibrillation. So that's all for the today's discussion, guys. And I hope you learned the ECG very quickly, very briefly, because this was just a 4-session discussion. All right. Don't expect that I'll be able to cover every point of it in 4 days. Okay. Some of the things I will try to cover in a quiz format as well. All right. So whatever things you think are left out will be covered, like hyperkalemia, hypercalcemia, all these things. So we'll try to cover that in the quiz format. The majority of the things which I think are important to know and I think are practically important to identify the ECG is what we covered in these 4 days discussions. Okay. Thank you so much, Harshal. I hope that you were able to recall everything, and it will definitely going to help you in your clinical practice as well. All right. So day one, we discussed about the basics. Day two, we discussed about all the waveforms. I tried to cover each arrhythmias with that part itself. Then on day three, we thoroughly discussed myocardial infarction. Starting from definition, starting from approach, we discuss about the biomarkers. We discuss about the each MI. I also told you about some minor, like for example, wraparound LED disease. I also told you about the proximal S1 segmental LED disease, etc. All these things we covered, right? So after that, we covered STEMI equivalent, in which we covered today deep winter's T wave. We covered posterior volume. We covered Wellens syndrome. We covered Sgarbossa criteria for the left middle branch block. All right. We also covered shark fin appearance for the STEMI equivalents, right? Then thoroughly discussed Wellens syndrome. We also discussed few part after that about the STEMI equivalent, that is Sgarbossa criteria. Coming to the arrhythmia part, we beautifully discussed all the bradyarrhythmias with some questions, interesting questions that gave you insight that on what part you have autonomic coverage, right? So in the diseases above the AV node, you have the autonomic coverage. That's why you go atropine in that cases. And in diseases below the AV node, that is bundle of His-Purkinje fibers, that is typically seen in the second degree AV, high grade AV block and third degree block. And that definitely you have to manage with what? Pacemaker. Then we came on to the discussion of the tachycardia, in which beautifully we know now that if it's narrow QRS complex, it has to be supraventricular. If it is broad QRS complex, it has to be ventricular, right? In narrow QRS complex, we discuss about that till everything, sinus, atrial tachycardia, multiple atrial tachycardia. We saw each of that ECG. Then coming to the atrial fibrillation, we beautifully discussed through all these flow chart on how to approach to the atrial fibrillation, what is difference between atrial fibrillation and atrial flutter. Coming to the ventricular tachycardias, we saw all the properties starting from positive concordance, negative concordance. We discuss about what is Josephson sign, that is S notch on the S wave, right? Nadir of the S wave. We discuss about the Brugada sign, that is RS distance more than 100 milliseconds. All right. Then we discuss about the what is fusion bit, what is capture bit. All right. Then we discussed about your Torsades point. We discuss about the ventricular fibrillation, and that's how the 4 days are summed up in just 1 or 2 minutes, guys. All right. I hope you liked it. Definitely, you have to revise it because I have been gone through this many times. So it's very difficult for you to just be that confident in just one go. But if you keep on watching these videos for 2-3 times and reading along with that and practicing ECGs daily, then only you will understand. All right. So I'll try to share some of the ECGs each day on the group, and I'll try to open the chat for all. But before that, I will share a form for you so that you fill that form. And if you fill that form today itself, I'll give you time for 2 days because some of the people might see this message after some time once, because they might be busy in their duties as well, right? So I'll share that in the group today itself about the form. You fill that form today, and probably you'll get certificates by the next week. About the quiz, I will share the questionnaires. You have to solve those 20 questions, and who gets the maximum mark, these 5 people will be playing a final round of the quiz with me, where I will ask almost 15 to 20 ECG to them. Okay, guys. I hope you liked. I hope you like that, everything. Yeah, I'll share whole PDF. I'll share today's notes also. So please don't worry about that part. Apart from that, if you want anything else, you can just message. All right, guys. All right. Yes, I will share the notes. Okay. Yes. Yes, please revise it again because it's not be covering. MI treatment will cover in the quiz only. No problem. Yeah, we're gonna share the video recordings, notes, everything we're gonna share. No problem about that. All right. So thank you so much, guys. I hope it helped. Definitely, this time is not enough to cover everything, right? 4 hours, or like we have covered till 6 to 8 hours. We have covered everything. So yeah, definitely. Thank you so much, guys. Just a quick survey. Which course you want to see? Like emergency medicine. I was planning for the emergency medicine, the next course. What do you think of? Shall we go for emergency medicine or anything else? Okay, good then. Good. We'll go for the emergency medicine only. Okay. Yeah, definitely. ABG will be covered in the emergency medicine, no doubt about that, because it's a part of the emergency only. Okay. Yes. Yes. Amazing. Amazing, guys. All right. All right. So thank you so much. And I hope everything I was able to share, you guys got it. Please revise that. Please revise the notes as well. And I will share today's notes in the PPT format or Adobe your PDF format so that you will be able to revise it also. Or if you want whole document of the annotated, I will also share that. Okay, guys. Signing off. Please share your review, and if you are there, we can just take a quick photo with all of you. If you can just turn on your cameras and your mics as well. So unless you turn on your mic, I'll not be able to see you. Okay. Please turn on your mic as well, please, guys. Okay, right. All right. Okay. So thank you so much, guys, for staying with me. All right, I'm taking a photo. Okay, bye. Wish you the best. Bye.
Bye,
Thank
sir.
you.